answer few questions.
We shall then go on to our next speaker, who is going to be elaborating on reading the FFA. He's a prolific vitreoretina surgeon from Sachitana Eyes Clinic. I don't know if I'm pronouncing it right. And with an expertise in diabetic retinopathy and retinal detachment. On to you, Dr. SRIKANTH.
Yes, thank you, ma'am. Yes. Hope the screen is visible.
Not yet.
Not yet. Okay.
Yeah.
Okay, so this is a short talk on interpretation of a fluorescent angiogram. And as you see, when you see a color fundus photograph, you might see a lot of red and orange and yellow, but a lot of details that we could miss. And the sepia tones sometimes reveal a lot of information which we would have otherwise missed, like neovascularization and a lot of microaneurysms in the perimacular area. And decoding the sepia tones is what we are going to learn today. So the main difference between looking at a fundus photograph and doing a fluorescent angiogram is the FFA is a time-bound test. So our photography skills and capturing of the images and timing is absolutely crucial. And on the right side, you can see a live FFA video that we have taken on an HRA, and this is how fast the angiogram FFA progresses from early at the choroidal phase to an AV phase and recirculation phase within a matter of 40 seconds. So capturing the images, concentrating on getting good quality photographs as a postgraduate is more important than trying to make a diagnosis while you are capturing the images from a PG point of view. Some trivia: this was discovered in 1959 by Novotny and Alvis, and they tested first on rabbits that there is an emission spectrum and an absorption spectrum, which is 480 and 520 nanometers. And finally, one of the scientists was the first human guinea pig to undergo the fluorescent angiogram, and they tested it on themselves. That's how confident they were about their test. So there is a blue excitation and a green barrier filter, which blocks the abnormal fluorescence and allows only the fluorescence from the structures to pass through and follow the camera sensor. The phases of the fluorescent angiogram: there is an early choroidal phase, which is within the first 10 seconds. And this is a diffuse background choroidal flush where the entire choroid glows up, and you can see some areas of choroidal infarct as a dark patch. And the arterial phase lasts for a very short 3 seconds, and the arteries fill up with the background of the choroidal flush. And then there is an AV phase, which is further broken down into a early AV and a late AV phase. This is the phase where we are going to look at the foveal avascular zone and the integrity of that. And within the first 40 seconds, the dye is already left the retinal circulation and reached the kidneys and is back into the retina in the recirculation phase. Abnormal fluorescence is further divided into either a hypofluorescence or a hyperfluorescence. Hypo is, as the name suggests, where the fluorescence from either the retinal vasculature or the choroidal background flush is blocked, either due to presence of blood clots or pigments or any other lesion that is not allowing us to view the choroidal fluorescence, or the overlying clot that is blocking the normal choroidal fluorescence, or hyperfluorescence, where there is increased visibility of the choroidal fluorescence, or there is abnormal leakage from an abnormal structure. This is the basic principle. This could be either hyper can be due to leak or transmitted fluorescence or pooling or staining, and hypo can be either blocked or a filling defect. So let's go to the hyperfluorescence types. Here, this is one very classic example of a classic versus an occult CNVM. In a classic CNVM, you can see that there is a filling of the lesion in the very early phase, what we call classically described as a lacy pattern of dye filling. The entire lesion fills up during the early arterial phase itself, and the lesion borders are very indistinct and feathery, and they start to increase in size. And by the end of the fluorescent angiogram, the entire lesion lights up, and you can see the entire size of the lesion. In an occult CNVM, the filling is very patchy because the distribution of the lesion is at a different plane, and you don't see the entire extent of the lesion as typically that you would see in a classic CNVM. So this is the main striking difference that you would see in a classic versus an occult CNVM. Other type of hyperfluorescence that you would see typically in a diabetic is due to microaneurysms. This is something that we need to see. Any lesion that we are going to treat within the macula, I would always recommend a fluorescein angiogram to map out the area that we are going to treat with laser. For example, this is a large area of hard exudates, but on fluorescein angiogram, we can see that the cluster of microaneurysms and the maximum amount of leakage does not really correspond to the maximum area of hard exudates. So the leakage is somewhere else, but the extent of hard exudates is somewhere else. So probably this would guide us to doing our laser very well. So you can see these light up as small stars in the sky in the early phase, and they slowly begin to leak and become clumps over the mid and the late phases. That is how a microaneurysm would look. The other typical example of a hyperfluorescence is ink blot hyperfluorescence that we see in a CSR. That appears as a small dot of hyperfluorescence in the early phase and goes on increasing as the dye accumulates in the subretinal space, and the lesion becomes larger and larger as described like an ink blot. And by the end of the late phase, you can see a large blot. So this is a typical ink blot CSR. Here, the site of leak is the defect in the RPE, where the choroidal and the retinal circulation dye is leaking through the gaps in the RPE and accumulating in the subretinal space. So this is another example where both hyper and hypofluorescence we can see in a diabetic retinopathy, where there is a large front of neovascularization that would start leaking because there's an abnormal blood vessel and the vessels are leaky, that would start leaking the dye right from the early phase of the angiogram, and the leak only goes on increasing to become larger and brighter through the mid and late phases. And you can see that the leak is more visible in the other areas of the neovascularization also. And you can also see an area of block fluorescence where the normal choroidal fluorescence is blocked by this presence of a pre-retinal hemorrhage. And this extent of blockage, which is blocking even the normal retinal vasculature, shows us that it is a pre-retinal hemorrhage. And this is another example where there is a diffuse leakage from a capillary blood where you cannot really distinguish any microaneurysms because the entire capillary bed is leaking. This could be in a diabetic, also in a pseudophakic CME, where you see a diffuse leakage, which is showing a cystoid macular edema or a flower petaloid appearance of the leakage by the late phase of the angiogram. And the third type of hyperfluorescence that we see is a transmitted hyperfluorescence, where the choroidal hyperfluorescence becomes more visible because the overlying RPE is absent or damaged, and that allows more of the choroidal fluorescence to be seen better. So this is one example in a sick RPE due to chronic CSR. You can see more visibility of the choroidal hyperfluorescence, which is an RPE track in a CSR. And also you can see active ink blots leaks, which are active leaks from a CSR defect. The third type is transmitted fluorescence in a geographic atrophy. The main difference in the geographic atrophy and the other types of hyperfluorescence is the size and the dimension of the lesion or the patch of hyperfluorescence doesn't increase over time. It remains the same and it may fade away by the end of the late phase. So that is the main difference that we need to keep in mind. So hypofluorescence can either be blockage of the fluorescence due to blood, either could be pre-retinal or intraretinal. When the blood is pre-retinal, it blocks all the structures underneath it, blood vessels, choroidal fluorescence, everything. If it's intraretinal, the blood vessels may be visible. Filling defect, where the dye doesn't fill that area at all. So you can see that as a black patch. These are the avascular zones, and this is very necessary to plan out your laser treatment. And this is one example. How do we read a fluorescein angiogram as a postgraduate? Which eye you need to mention first, which quadrant of the angiogram are we seeing, we need to say, and what phase of the angiogram are we looking at, and what is the kind of abnormal fluorescence, whether it is a hypo or a hyperfluorescence, we need to mention, and how does it change over time? Does it increase in size, intensity, and over time, and does it fade away by the end of the late phase? And what is the likely cause of abnormal fluorescence? We may commit to a diagnosis, but it is not an absolute must. So that's it. Thank you.
Thank you very much, Dr. SRIKANTH. That was also again extremely good. So back to one question from me. So what are the clear indications for doing FFA in a diabetic retinopathy?
In a diabetic retinopathy, now that we are migrating more towards OCT-based treatment, especially for macular edema, and which are basing more of our diagnosis for a PDR based on fundus photos and clinical examination, there are certain situations I still do a baseline fluorescein angiogram in a patient where I can't really correlate the extent of vision loss and the extent of macular changes. In cases where the edema is very minimal, but the gross vision loss, and I suspect a macular ischemia. Or in a patient where the retina looks absolutely fine, but I can't really explain the loss of vision, could be a featureless retina. And those are the two cases where I still depend on a fluorescein angiogram as a baseline investigation to map out the extent of ischemia and also the areas of leak.
Thank you, Dr. Srikanth. The quick thing, what Srikanth said, very nice presentation. I just want to add before I ask Muralidhar sir to please give few comments on this topic. So whenever a question is asked on this, he has very nicely explained the interpretation of an FFA is very important. We have seen, we just conducted the postgraduate education program just 2 weeks back in Hubli, and I could see most of the postgraduates entering it as, sir, it's a case of CSCR. So it's a case of ink blot pattern. So what I would rather suggest is first ask for the clinical findings if they give it. If no, if they give you a single frame, at least first identify whether it's a red-free, pseudofluorescence or autofluorescence, and then go in for which eye it is, whether it's a right eye or the left eye. And then you can go in for any arm retinal delay time. And then I have made a small mnemonic as SAM, sequential, anatomical, and morphological. Sequential in the sense phase by phase. I've seen many of them directly jumping into saying, sir, this is the case of DME. Which phase it is? If they give you this phase-wise, it's always better to identify phase-wise. If you get a single picture, which phase it is. Anatomical is whether it's a choroidal, subretinal, pre-retinal, and M stands for morphological. Then you can comment whether it's on hyper-FAF or hyperfluorescent. Yes, Muralidhar sir, your comments and thoughts on this, please.
Yeah, thanks, Srinivas. Good presentation by Srikanth. See, when postgraduate, if in the exam, if you are given a fluorescein angiogram, as you rightly said, how to interpret it, it depends on whether you are given a single frame. Sometimes you have a large print of a single frame. In that situation, what you need to do is you have to identify the eye, whether it's right eye or left eye, whether to identify what phase of angiogram this is, and then go on to describe whatever abnormality you say. You can say, I see an area of hypofluorescence which is irregular, near the disc or near the macula, whatever anatomical description you want to give, you need to give. And the end, as you rightly said, you can give a diagnosis, or you can say, with this information, I can't arrive at a diagnosis with this single frame. If you are given a series of prints of both eyes, then you can describe this is a fluorescein angiogram, describe the sequential event. The right eye in the early AV phase shows this, in the AV phase it shows this, and the late phase it shows this. And similarly, in the left eye, in the early phase, arterial phase, it shows this abnormality. In the arteriovenous phase, it shows this abnormality, and then in the late phase, it shows this abnormality. And that's why I think it's a leakage and not a a window defect or transmitted fluorescence. Like that, you can offer your explanation. So basically, you need to look at the angiogram and describe how you interpret it, so that the examiner knows that, okay, this fellow knows how to read an angiogram. That's all he needs to know.
Exactly.
I think it's better to, for yourself, only put it in the beginning that the minimum requirement for completing this fluorescein angiography would be a color photograph and 2 phases, one early and one late phase of the angiogram. Yes. If you're giving me only one and you don't want to give me the other, then I can only say hyper or hypo. I can't even say whether this is transmitted or increasing. So I can only comment on the fluorescein angiographic picture. I cannot comment on on what comes as a functional change in terms of leak, in terms of window defect. One picture you can never comment on, and you should not also. So, I mean, this is very important because that can be a trap for you also otherwise.
Very, very valid point. Very valid.